for jewelry. So earrings, necklaces. With our older patients, sometimes if they have dentures, we'll ask them to remove that, especially for the open mouth view. So all of that you want to have removed ahead of time. That way you don't have any foreign objects in the way of your anatomy. Glasses, Emma's wearing glasses. That will also play an impact, especially on C1, C2. On your lateral view, the hooks that go around the ears will come right over that region. So you want to have them remove their glasses as well. Patients that have, for our female patients, you want to be mindful of any pins or like ponytail holders that have metal on it, because sometimes that will come out over the C1, C2 area. So just move as much foreign areas, foreign material as you can. All right. So the positions we're going to go over today are going to be, I think there's 6 of them. So we'll do our AP, both of the obliques, the open mouth, the lateral, and I'll show you guys, well, we'll save the swimmers for next, I don't know if I want to do the swimmers today or next week. Well, let's start, and if you guys feel like it's a lot, we'll save the swimmers for next week to kind of throw that in with the thoracic spine. All right? So we'll start off with the AP. Again, you can do this with the patient either laying on the table or standing up against the wall, Bucky. I prefer to have the patient stand up, but you know, based on your patient condition, that might not always be the case. You might have a patient that has a leg injury, or they're immobilized, or they're at risk for falls, and you have to do it laying down. But I'm going to show you guys how to do it standing up. So what is our central ray? What are we aiming at? How's our central ray for the
C4.
AP? C4. So it's not perpendicular, the central ray.
Oh, yeah, it's angled 15 to 20 degrees.
So we're angling. And why do we do that angle?
To get as much of
To get the dens and to make sure the atlantial axial, you can see it open.
So think about what vertebrae we're going to see on your AP, okay? So are we seeing all of our 7 cervical vertebrae on the AP?
No.
So which ones are we seeing?
2 through 7, or 3 through 7.
3 through 7. And why can't we see 1 and 2?
Behind the
it's-
skull, mandible.
Because the mandible's in the way, right? So the reason why we're angling is to get much of the cervical spine as we can see as possible, but also we're angling because remember we talked about the normal and abnormal curvatures of the spine. What type of curvature does the cervical region have?
Lordotic. Lordotic.
So lordotic or concave.
Okay.
So because of that natural curvature of the spine, I gotta bring Fred back in here. Because of that natural curvature of the spine, that's why we're angling. We're angling to open up the intervertebral joint spaces, because if we just left the central ray perpendicular, that joint space is gonna be closed. So we're not gonna see it open because of that natural curvature in the spine. All right? What are some of the things that you should be seeing on your radiograph for the cervical?
The AP or just
For the AP.
The teardrop
the
going down the center.
So
spinous
we're-
processes?
Spinous processes.
So you
Processes.
wanna see spinous processes right in the center. What else?
The pedicles
And where would the pedicles be?
on the sides.
Anything else?
The
Or, what is the joints? I wouldn't say zygopoxial, but I'm not sure.
that's on the lateral.
You gotta know that. That's for sure gonna be on your test.
The intervertebral joints space
So
and the anterior not anterior superior and inferior what is it called? What is it called? I forgot. But I know it's like on the sides, like in between the spaces. Like
okay.
superior, inferior,
The articulating process.
yeah.
And also the vertebral body, right? We're gonna see the vertebral body right nice in the center. So Ms. Wallace brought Fred in here. So let's was talking about, the cervical region has a concave, type of curvature or also lordotic. We're also gonna see that same type of curvature again in the lumbar region. Thoracic and the sacrum region are opposite. They're convex, all right? And those are a type of curvature known as either convex or kyphotic. Okay? All right, so let's get into the positions. So Ms. Wallace is gonna be my patient. So the receptor.
But Wallace, you really need these, you really need them today, huh?
So the receptor, you can really do all of these images on a 10 by 12 if your facility has it, but I know a lot of the facilities may only have this larger one, the 14 by 17, so you could collimate in quite a bit, okay?
What you need?
No, I wanted to show them the air trick with the 10 by 12 receptor. I'm not gonna use it, but I just wanted to show them it. So if you were using a 10 by 12, which is the smaller one, once you have it in place, remember we talked about in our presentation, a good way that you could align the central ray with C4 is putting the top of the receptor at the same level as the patient's, the top of the patient's ear.
Okay.
Okay, so you could use that as a reference, and then once you do your angle, make sure you're centering to the center of the receptor. Okay, so that's a good way. Or we're gonna use the larger one just because I don't think that one's gonna hold in there. You could look at the thyroid cartilage region and kind of aim for that because that's more so in the same vicinity. It's gonna be more prominent on your male patients, but you should be able to see it a little bit on your female patients as well. If you are using a smaller receptor, you want to make sure that you have it. How's this position called for our receptor?
Portrait.
Portrait. So you want to make sure that the receptor is portrait, because again, you want to go with the long axis of the anatomy that we're examining. So the spine's going lengthwise this way. So we're going to put our receptor portrait. What's our SID for the AP?
40.
Okay. Oh, really quick, because we're, you know, with the seniors, they're about to graduate, so we're doing registry review with them. We're doing a lot of registry style questions, and we're gonna start incorporating that type of questions with your material too, so you guys are starting to get familiar with those questions. But one thing I came across with the seniors is there was a test question when you're doing either a cross table lateral or you're doing an x-ray upright using the wall bookie. What is the angle of the x-ray tube? So your options were 0, 45, 90, and there is no angle, or something else. So what would the angle be?
90.
90. Okay, I just want to make sure you guys understand that, because even though we're a lot of our upright studies, the x-ray is perpendicular, the positioning, and because we move the x-ray tube head in this fashion, it is a 90 degree. Okay, and even if you come over here, it'll say 90 degrees on it. So I don't want you to think it's 0 because there's not like an angle on it. Okay. So we're putting 15 degrees on it. Is it cephalic or caudad?
Cephalic.
Correct, cephalic. So we're going up towards the head. Alright, so I got my 15 degrees. Now I'm going to come down and make sure I'm in alignment with my receptor. Okay, so I'm aligned there. And sometimes when you're doing angles, this might be off a little bit. Like you see how it's centered here, but it's like a little off there. That's okay. That little bit of difference is not going to make a big deal, but you just want to make sure that you're in the center as much as possible. All right. So what do I need to do now?
Raise it up.
Why am I raising it up?
Just here.
Because your line is not in with C4.
Mm-hmm. So we're going to raise it up because the crosshairs is all the way on Miss Wall's chest. So I need to bring this up. because I wanna make sure my crosshairs is at the level of C4, which will be about there. Alright? Now, I'm gonna center my patient, okay? Cause you, again, you wanna make sure the spine is nice and center. Alright, so you wanna go along the mid-sagittal plane. We could bring in our collimation quite a bit, so just to the skin borders. And usually, as far as top to bottom, if you put the top of the collimation right underneath the bridge of the nose, that's typically enough as far as lengthwise, and then just bring it into the skin borders from side to side. What else do I need to do?
Label, mark it.
Mm-hmm. So I'm gonna put my marker on there. What else?
Shielding, shielding.
Right, so if it was a real patient, I would remove her necklace and also
Her earring, shielding.
So, like I told you guys, we're still going to practice shielding because it has not been taken out of the curriculum. I know a lot of the sites are not actively doing that, but we still want you guys to shield because that's what is in the curriculum.
Okay.
So, everything look good?
Chin up.
Why are we doing the chin up?
To get it out the way.
So we want it up a little bit because we want to see as much cervical spine as possible, so we don't want it to overlie that C3 region. Everything else, does everything else look good? I don't think we're at 40. So you guys happy with that?
Mm-hmm.
You need to recheck the.
Recheck the, and bring the collimation up to her nose, below her nose.
Okay.
Well,
What else?
check the, make sure the, IR is lined up too.
Is that good?
Yeah,
So one thing's off.
what's off?
You guys tell me.
Oh, her necklace?
No?
She's got earrings.
Well, we'll
We're pretending.
yeah, we're pretending
Okay.
all that's done.
Oh, her mask is on. Take the mask off to take this one? No, that's for the odor.
You could, I mean, it'll penetrate through the mask.
Okay.
But, what about the marker? Mm-hmm. So, mm-hmm.
Couldn't see
So-
that far.
I've got the left marker on her right side.
Mhm.
So make sure you guys are using the correct markers, okay? It doesn't matter what marker you utilize, just make sure you're marking the correct side. I like to use the left one, and I put it right there, because when I go into my lateral, I just leave it in the same spot, and it's usually good. It's gonna be out of the way, and I already have my marker on there. So questions of the AP? All right, so since I have my ankle on here, I'm gonna go into some other positions that require an angle for the cervical spine. So what are the other positions that we need to angle? So we're not gonna do the fugues today, because that's a specialty view. We're just doing the regular routine positions.
For the, AP and the lateral and let's see. Oblique.
Yes, oblique. So you guys should know this. Y'all got a test on Monday. So we're angling for the obliques, okay? Our lateral view and our open mouth, we don't angle. Those are perpendicular. So we're angling for our obliques. Am I gonna leave the angle cephalic like it is now?
It depends if it's anterior oblique or posterior.
Mm-hmm. So if I wanna leave it cephalic, because it's already cephalic, how should I position my patient? Would it be anterior oblique or posterior oblique?
Posterior.
Correct. All right. So you don't have to do all 4 obliques. You do have to do 2 of them, but you need to determine which two you're gonna do, either anterior or posterior. So I typically like to do posterior obliques because my patients are usually going to be in that position anyway, coming from the AP. So I'm gonna have her posterior aspect against the board, and I'm gonna do my LPO and RPO, and I've already got my angle on my x-ray tube. It's already still aligned to my receptor, so it's just less moving parts, all right?
Mhm.
But again, you can do it however you like, you can do it however you're comfortable once you start getting more of these, under your belt.
On the lab exam, will it be, like, will you give us like a, whether we have to do LPO or APO or RAO?
I think what I'm gonna do is I'll do either or, because you know those obliques are pretty much opposite of each other. So I'll say either do a LPO or RAO, and you can pick which one. Alright, so let's start off with the LPO. So I'm gonna have Ms. Wallace put your back against the board for me. And I'm gonna have you lean or turn towards your left side a little bit. How much are we rotating that patient?
45.
45 degrees, okay? And then, Ms. Wallace, go ahead and look and turn your head towards the left. So again, like Ms. Clark was saying, some of your patients may not be able to do that based on their pain, or if they're in a collar, you don't want them moving around a lot, so just go with what your patient can tolerate. Still keeping my SID at 40. I've already got my angle on here. I do need to make an adjustment because my central ray is a little low, okay, because her position changed. Do you guys see how it's low? It's like more so on her clavicle region.
Mhm.
I've got to bring it up because I'm still aiming for C4. All right. Are you guys able to see? Okay. Do you want me to turn off the
I
light?
can see,
I can see it
perfect.
right
Okay.
now, too.
So I'm gonna raise this up a little bit to the level of where C4 would be. I'm gonna bring and make sure my receptor is aligned as well. So, and then you wanna, remember we talked about when we were doing our obliques of the abdomen using the ear as a reference, because the ear is going to be in alignment with the center of the spine when you're doing obliques. So I've got her 45-degree rotated, and I'm gonna center right where her ear is, okay? And that's gonna put my spine in the center where I want it to be. Not gonna make any adjustments with my collimation, because I'm still doing the same region, all right? So nothing to change there. And then I already have my same left marker on her left side. I'm just gonna bring it in a little closer to make sure it's in the field. I always like to mark the side that's down because it's less confusing for the radiologist, okay? I mean, technically, if you put your marker over here and put the right one, you're still correct, but the radiologist is gonna get thrown off by that, because they're gonna see that the anatomy is positioned for a LPO, but the right marker's on there. So it just kinda makes it confusing, so I always like to mark the side that's down, or closest to the receptor. When we do our patients in the obliques, what are we seeing? What is the main thing that we're seeing? I know we're seeing a couple of stuff, but what did I tell you guys we're gonna see in the obliques? You can relax, Miss Wallace.
The zygapophyseal joints, the intervertebral joints, the
Vertebral foramina, is that a good?
yeah,
So we're seeing the intervertebral foramina. The zygapophyseal joint is gonna be seen in profiling the lateral, okay? But the obliques, we're opening up that intervertebral foramina.
And
Yeah.
it's doing the one that's closest
To
to the
the-
IR, or
Yes, so make sure you know that, because that's definitely gonna be on your test.
See where it says intervertebral?
What intervertebral foramina we're seeing based on which oblique you're doing. And make sure you know all four, because I might give you all four. I might give you 2 out of 4, I might give you 3 out of 4. So make sure you know if I'm doing an RAO, I'm seeing this intervertebral foramina open. If I'm doing an LPO, I'm seeing this intervertebral foramina open. All right?
so LPO, you're gonna see the right foramina, right? The one furthest away, and
open.
then RAO, you're gonna see the one closest, so you're still gonna see the right, am I?
Yeah, because remember your LPO and RAO are basically opposite.
Opposites.
You're seeing the same thing. Does it have that detailed in your little book?
It
No.
just says furthest from IR,
Okay.
closest from IR.
Okay.
That's why I was trying to get like
The
clarification.
left and the right.
Yeah.
And make sure you know, it's good to know that opposite terms too, because sometimes you'll see it like that. It might not say the right side is visualized or the left side appears open. It might say furthest or closest to the receptor too. Alright, so right oblique, same thing. We're gonna have our patient 45 degrees. We wanna make sure we're using the alignment with the ear. Go ahead and look straight at the wall ahead of you. I'm lined up with her ear. Now I'm gonna switch my marker and put my right one there. Again, I don't have to make any adjustments with my collimation because I'm still in the same region, but I'm in alignment with her ear. I've got my correct marker on there and I still have my angle. Alright, so what position is this?
RPO.
So this is my RPO. Alright. So let's do, what do we have left?
Lateral.
So lateral, so what are we changing with the lateral?
Perpendicular in the SID.
Okay, so I got it perpendicular now, what's our SID?
72.
Okay, watch yourself, Angel, I'm not sure how, okay, you're good. Why do we go to 72?
Because it's further from the OID.
Correct, and where are we seeing that OID?
Between the shoulder and the IR.
So I go to 72. I gotta make sure I come back and make sure I'm aligned here. I'm gonna ask my patient to put their left side against the ward. Sometimes your patients get thrown off when you ask them left or right. So sometimes I just will say, you know, turn away from me or turn towards me, might just be easier terms as well. This is the one that you wanna make sure their shoulders are really relaxed down at their side. And why are we doing that?
To get the shoulders out the way for the C7.
Right, because we have to make sure we have all 7 cervical vertebrae on this lateral image, and sometimes the shoulder region will be superimposed on our C7. So we want their shoulders relaxed as possible. If there's no concern or they don't have a shoulder injury, sometimes we'll give them weights to hold, especially if they're like really broad-shouldered individual. We'll just have them hold weights or sandbags in either hand to help bring their shoulders down as well. Or sometimes we could do that swimmer's view that we talked about, okay, where you're separating the arm to get the separation of the humeral head so we could see in that region a little better. But for your normal lateral, this is how you would appear. I'm going to have her come a little bit closer because, again, our spine is a little bit more posterior, so I want to make sure I'm in alignment with the spine. I'm going to put my marker on here. Remember we talked about raising the chin up a little bit because we want to make sure we're not getting that ram eye superimposed with C1 and C2, so we have them slightly elevate their chin. I'm going to bring in my collimation because since I went out to a larger SID, it increased my field size. So I'm bringing in my collimation, and I'll ask the patient to hold still and not move, make my exposure. For patients, if you're doing it upright, sometimes they kind of tend to sway and move around a little bit. If you have a patient that's doing that, you can bring an IV pole or a chair in front of them to kind of hold on to, or have it holding onto the chair off to the side, and that kind of stabilizes them a little bit. If we were to do flexion and extension with this view, everything would remain the same. The only thing I'm going to do is tell my patient for one of them to look up to the ceiling, and I'm still going to be on target with my centering, but you just want to double check in case the patient moves slightly. So that would be, which one would this be out of the flexion and extension?
Extension.
So that's my extension, and then I'll ask them, make my exposure, ask them to go ahead and look down at the floor, would be my flexion. Okay. For these, you wanna, you can use those markers that will say flexion and extension on them, or just make sure you can relax massage, you annotate on there so the radiologist knows which one. I mean, they'll be able to determine by looking at the anatomy because you're gonna see the differences and how they appear. But if there's a pathology going on, or the patient may not have that full range of motion because they were in a car accident and had, you know, whiplash with their neck and stuff, and may not really have that difference because there's not that full range of motion.
For the
test, are we gonna need to know, like in the book, how it has like different pathologies that are like specific to certain?
You will, but not for this coming test. I have a PowerPoint on pathologies that I will touch on when we get into lumbar spine. I don't think I'll get to it next week because we didn't get
You
into,
had your coffee.
the full amount of thoracic yet. But I will go over some common pathologies that affect the spine. There's a lot.
You gonna do the
Yeah,
swimmers?
it's a lot. Yeah, every chapter, when you look at the end of every chapter, they always have like pathologies that affect that region. And I don't go over every single one, like it'll just be so much. But I usually touch on the ones that are more common and that you'll see a lot.
Miss Hilbert, you gonna do the swimmers while she's in the lateral?
Well, we've got technically two left. We got the swimmers and the open mouth. Like, do you guys want me to do the swimmers, or you prefer
Yeah.
to show that?
I do, 'cause
Yeah.
they always
Okay. So for the swimmers, you might see both. You may see the SID stay at 72, or they might bring it into 40. I'm gonna bring it into 40 because that's what I usually do, and then that way I'm already at 40 for my open mouth. But you may see both.
Seems close.
I'm sorry. Why is it so long? Okay, I must have just sorry. All right. So for your swimmers, you actually want to center a little bit lower than C4 because you're not so much concerned about getting vertebrae 1 and 2. You want to make sure you get that C7, and you'll also see the interaction with T1 as well. So I'm going to bring it down about an inch. And again, we will have the patient stay in that left lateral. Their arm is going to come up. You can use the P-bar if you have one for them to hold on to. If not, just have them bring their arm straight up. The opposite, the right side, you want to relax down. Again, I'm going to have Ms. Wallace come a little forward because we want to make sure we're in the center of her spine. And I'm going to open back up my collimation. Ms. Wallace, come forward just a tad bit more. Okay. So now I'm in center with her spine. I still have my left marker on there, which is correct. And, what else? You would have them lift their chin, okay? So you have them lift their chin to make sure the rami is away from the vertebra as much as possible, and you would make your exposure. All right? By doing the arm separation, we're separating the humeral heads, and we'll be able to visualize that C7, C1 region right in between. Your technical factors is also going to be changed for this. All right? What do you think we're going to need to do with our technical factors? So we're increasing. Why are we increasing?
Because now you have.
Now you got a humerus in the way.
So we're going through a thicker area, all right? We're not just only looking at the cervical, now we've got to go through our shoulder region. Okay? All right, last one, open mouth. So open mouth, I always bring my collimation in because you're going really close to the eyes. So you don't want to like turn on the light and have it all in the patient's eyes. So I can try to close in my collimation so when I do turn on my light field, it's not like blinding them. Okay? I've got to bring it up because you're aiming right for when the patient opens their mouth, you're going to aim for the crease of the mouth. So you want to go ahead and bring it up into that region. And what are we trying to get in alignment with this?
The incisors.
Yeah, the inside, the top incisors, and the occipital bone in the back.
Yeah. So you want to get the top of your teeth in alignment with the occipital portion of your head. And you can feel that bump back there, okay, that inion. You can feel that, and that's the region that you pretty much want to have an alignment. So you're going to either lower or raise up, tilt the patient's head up and down in order to get those in alignment.
Okay.
Okay? Make sure you tell the patient beforehand what you're doing. Let them know that you're for this last view or for this position, we're going to have you open your mouth. because we need to see the top two parts of your spine, okay? The teeth are gonna be in the way, so that's why we need to have you open your mouth, all right? Also, this is the one that you wanna make sure, you remove any dentures or any oral work, if they have anything in their oral cavity that could be removed. Just don't lose the patient's dentures, make sure you give them right back to them. So,
Almost done that. I put it in the paper towel, I put it to the side, and then I'm kind of cleaning up or whatever, and I'm like, oh, no. I've almost done it several times.
yeah, so make sure you're careful with that. So, we're gonna ask the patient, go ahead and open your mouth. I feel for her inion, raise your chin up a little bit. So now they're in alignment.
Okay.
I'm coming in right at the creases, and that's your open mouth. You can see how small the collimation is,
Mm-hmm.
because it's just for C1, C2,
Okay.
okay? I still have my left marker on there. And that's another reason why I like to use my left marker, because it just comes in handy for the majority of my positions. So my left marker's still there, it's in the collimation field, and that would be your open mouth.
Okay.
So why would you do, like, or why don't they do, like, because I feel like some people probably have a hard time keeping their mouth open like that. Why wouldn't you just do the I can't say.
The fuchs, because the fuchs primarily shows the dens of C2, you're not gonna see C1 as much. You'll see parts of the posterior arch and the anterior arch, but you won't see the lateral masses on C1.
Okay.
And you won't really see the atlantoaxial joint space either.
So the fruits is
The fuchs we'll
It's
do
AP.
next week, because it's easier to do that one laying down. So when we have the patient laying down for a thoracic spine and lumbar, we'll do that next week.
yeah, because I seen it in the book where the fruits is AP in the what was it the one that you turn PA for and put your chin up.
Yes.
What is that one? The Jude.
Yeah, but
The Jude is PA, but the fruits is AP.
But I wouldn't be like, I would just know that the Jude is there and that it's PA and it exists and what it's for. But you're never really gonna see that
Okay.
in the clinical aspect.
Okay.
So Danielle,
Yes,
you
ma'am.
still kind of, for C1 and your odontoid, you're still kind of teaching us some of the probation things, you took that. You're still not doing that.
Yes. So
Which one? The fruits?
No,
Don't.
it's the whole cervical spine.
Yeah. I've been seeing it a lot at Camp Creek. You see it where you at?
I saw on my website a bunch of times. Yeah, they want to compliment it. It's like I can't because I've.
You haven't learned it.
I used to see it at my first
Rotation at the
a
pain.
lot. That's
Yeah.
all I used to do.
Like car accidents and stuff like that. So I've always seen it.
Where you at?
The AMC side.
Okay.
No, the last.
Now you at Maine.
I haven't seen any spines down there lately.
You done did that's what I was thinking too. 'Cause I know he was doing a lot at
But they can't.